Welcome to part 3 of the 4-part series. This will be our second and last Zoom session, and I'll talk a little bit more about what the final session is going to look like at the end. Today we'll be focusing on systems navigation and kind of how to navigate those systems to find the right resources. And we're going to be focusing on 2 different systems, and these systems kind of work in parallel to each other, even though oftentimes we need resources from both of them. It's kind of one of the more frustrating parts of navigating these different systems, is that a lot of these different areas kind of are siloed off from the others, and that can sometimes make it challenging to navigate. So the ground rules remain the same as they have for the other sessions. I'm not going to answer any questions about treatment plans of a specific child. I'm not going to comment on specific recommendations from specific treatment providers. If the question is formatted in a hypothetical nature, that is okay. So by the end of today, I'm hoping to have reviewed a little bit about the history and the organization of the foster care system. And within that, we'll talk about some different legislation over the last few decades, and with some focus on more recent legislation and how that's impacted the resources available to families and professionals working within the foster care system. And then we're going to review the organization of the mental health system so that we have a good idea about how to kind of navigate different levels of care and what to expect at different levels of care. And then this last point about the resources, we're going to address some of that next week, but I'll also have a handout to send out to all of you with some resources that you can utilize in both areas, in both systems. So we won't do actual breakout groups. We're going to do just one group because we've got, looks like 4 people, and then I'll help kind of mediate this. So I've got 2 questions I want everybody to think about, which is, how well do you understand the logistics of the foster care system, and how comfortable are you navigating that system in order to find the right services and resources? So think about that for a minute, and then if anyone wants to jump in with any thoughts, feel free.
Yes, Mark. I can try to answer both questions. How well do I understand the logistics? Not so well, because it looks like every state is different and even county to county is different. So that makes it very difficult to understand. And then there are rule changes over the last few years too, which makes it more difficult to understand. And finding the right resources and services is sometimes difficult, and you have to rely on that you know somebody who went through it, or have a foster care agency or a county worker who can hook you up with people.
Mm-hmm. That's a very good point you brought up that we'll address later. The fact that not only is the foster care system siloed from other systems, it's different, not just state by state, but in some states, county by county. We'll talk about that a little bit more, because the structure of the system in each state is different, and there's not a lot of national oversight in this area. And that makes it really challenging, because rule changes don't always affect everybody the same. So, because the rule changes are not coming from a federal level most of the time. So that makes it really, really hard. Mark, if you don't mind elaborating, like when it comes to looking for resources, You mentioned like sometimes, it helps to be linked up with an agency, or it helps to be linked up with a care coordinator. What have been your experiences with those resources?
Hit and miss. And that's why, because we had around 10 foster children over several years, and depending who's working with you, sometimes you have somebody very good and they said, oh, you can send their resources or contact this person. And sometimes you have people who are overwhelmed or who have too many cases. And in one case, I think we had 5 Erie County caseworkers on us.
Mm.
On it. So it doesn't help that one caseworker gives it to the next person and they thought you know something or they told you and things like this. So it's hit and miss. It depends on who you have. And there are some very good people and there are some people who thought you know this, but you don't.
So there's a wide range of knowledge, and there can be some volatility because in the area of care coordination, there can sometimes be a lot of turnover. That's a good observation too. Does anyone else have any thoughts on these two questions?
You can feel free to unmute yourself to answer if you have something to say, or you can put it in the chat, whatever you're more comfortable with.
I was just going to agree with Mark with the agencies. I work with an agency and they were always very helpful with what we can do and reach out to do for the kids. I think if I was just with county, I wouldn't have gotten as many answers.
So again, the knowledge base can be very different, and some of it I think too is just the time availability to for those coordination resources. That makes a big difference too. So what we're going to do next is we're going to talk a little bit about some important legislation that has come into play over the last, we're going to go back about 40, 50 years. And the reason for that is, if you recall from last week, there were multiple times where we were discussing treatment paths and the different barriers that come up and the different viewpoints that have kind of come down from legislation about like what dictates a particular treatment plan, what dictates what things dictate placement for a child and where a child is placed. And I had mentioned that we were going to talk about how the pendulum has swung both ways, and it's been very hard to find a good balance. And we're going to kind of walk through why that is. So we're going to start by going all the way back to 1974. And that was the creation of the Child Abuse Prevention and Treatment Act. And this was coming up because it was within the last 10 years that the knowledge of kids being abused and neglected and struggling in different family situations was finally getting some public attention. So, because prior to this point, there really hadn't been much. And it was about 10 years earlier that the medical community first started talking about it too. And there's a particular paper about it's called the Battered Child, which talks about the medical things to look for in child abuse. So the Child Abuse Prevention and Treatment Act was the first attempt to create a more unified identification and investigation system, both for reporting and then for prosecution of offenders. And essentially the funding from this is what led to the first child protection agencies being formed. But as we're going to talk about, again, this was state dependent. There was not some umbrella of federal funding that was given. States were directed to work with their own funding sources. And so a lot of these systems looked very different. So what happened here is with the creation of child protection services, you started having a lot more attention to these kids who were struggling in their homes. And because of that, there was a large increase in the number of kids that were getting removed from their biological homes and like permanently removed. And this got to the point that the federal government decided to kind of react to that. And 6 years later, in 1980, the Adoption Assistance and Child Welfare Act was created. And this swung the pendulum the other way because of how many foster placements kids were ending up with. So it created a definition of children in need of placement or services. It created more funding for adoption assistance. But the big thing to take away from this piece of legislation was the idea that it stated there needed to be reasonable efforts to prevent placement and return to the child to their biological home as soon as possible. It did not go into any more detail than that. And again, with this being a state-dependent system and sometimes a county-dependent system, everybody interpreted this a little bit differently. However, most areas determined that this meant we have to do everything we can to keep kids in their biological home, no matter what. So now, instead of concerns about too many kids being placed out of the home, there were concerns about kids who were not being removed from unsafe homes in the first place. So now this kind of stayed that way for quite a while, because the next piece of legislation that kind of reverted things back a little bit didn't happen until the late 1990s with the Adoption and State Families Act. That was 1997. It created one of the, I'm going to say, well-known phrases that's used in the child welfare system when it comes to determining treatment plans, and that's looking at the well-being of the child. That was the new buzz phrase in this piece of legislation, which again is a very vague term and opens itself up to a lot of interpretation. But no longer was the blanket statement, you need to try to get the child reunified with their biological family. And one way that this piece of legislation helped enforce that was it created something called the 1522 rule, which meant that if a child was placed out of the home for 15 months out of a 22-month span, the legislature, the legal system was automatically required to start the process for removal and termination of parental rights. And it also dictated a need for permanency hearings every 12 months so that the legal system was checking in more on these kids. So as you can see with all this legislation, there's a lot of big pendulum swings, and there's also a lot of vague language in these pieces of legislation. So every state interprets it a little bit differently, which is, you can get some very different approaches in different areas of the country and different areas of a particular state. And that also, I think, influences why there's so much difference between the knowledge base of all the different professionals working in this system, because it's based on a lot of vague terminology. So, over the last two decades or so, legislation has more been focused on promoting awareness and funding, which is a good thing. Although it hasn't reestablished that definition of the well-being of the child and hasn't really expanded on it anymore. We had the Fostering Connections to Success and Increasing Adoptions Act of 2008. And what this did was it allowed grandparents and other relatives to kind of acquire the benefits that foster families had when it comes to taking guardianship of a child. And it also provided more funding to agencies involved in the system. And then in 2011, there was the Child and Family Services Improvement and Innovation Act, which is more about monitoring. But I bring this up because one of the things that this act has led to the monitoring of is whether or not kids in the child welfare system are on psychotropic medications and what kind and how much. So it's given us some data about what happens with these kids in terms of medicines. I mean, the unsurprising main takeaway is these kids end up on average on more medicines than the general population. And we kind of talked about what leads to that the first 2 weeks. But this piece of legislation has basically given us some objective data to back that up. The last piece of legislation that we're going to talk about is a relatively recent one called the Family First Prevention Services Act, and this was in 2018. And what this did was it expanded the reach of funding. So no longer did this just apply to kids already in the foster care system. This funding could be used for kids who are at risk of entering the foster care system. So perhaps a family who's received a couple of CPS calls that may or may not have been founded, but the child hasn't been removed yet. They would be more in line to access services through this funding. You know, a child who has a very difficult life circumstance, say a parent passes away, and maybe school is getting more concerned with the reports from the child about home life now with just one parent. If they felt that was at risk, that kid was at risk, they're now eligible for some of this funding and some of the services, with the idea that we want to try to prevent kids from undergoing the trauma of placement in the first place. If you kind of remember, we talked about that in the first session, that going into the foster care system itself is traumatic, and each placement after that is further traumatic. So this link at the bottom is information for how New York State is interpreting this piece of legislation. Again, every state does this differently. So the way New York does it is different from the way New Jersey does it, and is different from the way Ohio does it, et cetera, et cetera. So this diagram gives a basic layout of the child welfare system. And there are national, state, and local levels. In New York State, most of the services are run at the county level. And there's no like state or group of states that functions under one like national umbrella. So the national level is more about information. So you have the Department of Health and Human Services. Within that, you have the Administration for Children and Families. And within that, you have the Children's Bureau, which kind of is the national voice for this system. New York State does have, or did have, some services under the Office of Children and Family Services. Those have changed within the last year or two. And then we get to like the real area where the decisions happen. And for us, that's at the county level in the Erie County Department of Social Services. And DSS is divided into three basic areas. You have foster care and adoption services, you have CPS, and you have children's services, which functions as a preventative branch of DSS. And again, you can already see how siloed this can be. Those three sub areas within DSS can be pretty siloed too. So that makes it even more challenging. So that leads to the question of where to find resources for families. Now, when I originally created this slide presentation, which was a year or two ago, there were three things we're going to talk about. And you'll see the asterisk next to state waiver programs, because we're not going to talk about that anymore. There was a program called Bridges to Health that kind of functioned as a statewide resource for families, but that no longer exists, which has made things more challenging. So oftentimes, the foster care agencies and other resource organizations are the best place to find guidance for resources. And sometimes those organizations can provide services. As we talked about a little bit last time, Mental Health Advocates has its foot in the wraparound services arena. Parent Network can provide some behavioral support for kids with developmental needs. EPIC does the Incredible Years program. So these organizations can provide different services. Now, pro and con, there's quite a few different foster care agencies in Western New York. That means there's a lot of places to get potential guidance and resources, but you're going to see some variation between the different agencies. But there are several agencies out there that can kind of serve as a hub for coordination support and kind of helping folks find the path to the right services. And then, you've got local mental health organizations, like I mentioned. There's Parent Network and Mental Health Advocates that have sponsored this series. There's also different organizations that are created by foster families, although they're not agencies. So you have the Western New York Foster and Adopted Families Association. You have the Adoptive and Foster Family Coalition of New York, which is more of a statewide resource, and the Coalition of Adoption and Foster Families Agencies. And those are other areas to find more resources, both just within their organization in terms of like websites and documents and things like that, but also ways, people who can help direct you to more resources. So a couple other resources I've listed up here. This is more about when kids in the foster care system transition into adulthood. And oftentimes these young adults don't have any idea what resources are available. And depending on their life circumstance, they may not have gotten much guidance as to how to look for resources. So it's good to be familiar with these. Adults in the foster care system may be able to access Medicaid, which can help give them more affordable healthcare options for some of these different services. And then there's extended foster care. And I believe we talked about this a little bit during the first session, but extended foster care essentially said, when foster kids exit the system as 18, when they're 18, that many of them still need services. We can't just like drop the floor out from under them and expect them to do well. So this program extended some of the services through the age of 21. And this is for, whether or not a young adult is within a foster family or not. And again, it's different for each state. So the link at the bottom, the sublink I gave you is for New York State. You can find different sublinks for other states just to get a sense of like, everybody does this differently. So it's very confusing. And it's really important to take the time to know what resources are available locally or statewide, especially if somebody moves. Particularly if a child moves and they're not going to be able to necessarily tell you what they had access to at the previous state they lived in versus the new state. So it's really important to keep that in mind because it's all different. So that's a bit of a whirlwind tour of the child welfare system in terms of legislation and some of the difficulties finding resources. We're now going to switch gears and talk about navigating the mental health system. So I have the same two questions as before, but now instead of the child welfare system, I want to get a sense of how well you understand the logistics of the mental health system and how comfortable you are navigating that system in order to find mental health resources for kids. Take a second to think about that, and then feel free to share your thoughts, either unmute yourself or put it in the chat. Now, it's okay. Now, in this situation, I would expect there to be both some positive and negative thoughts about trying to navigate this system. as somebody who has had to try to navigate it, myself, for kids and families in a number of different ways. There are times where the system can work very well, and there are times where the system breaks down and doesn't work well. Any thoughts?
I think it's hard for to find the right counselor, depending if it's a child or an adult. Like, I might think someone's a great counselor, but someone else may not have a connection or that trust with a counselor. And
Mhm.
into a specialty, I work with the brain injury population. If the counselor can't understand the brain injury, it's hard for the brain injury client to relate with that counselor.
That's a very good point.
'Cause anyone
So,
can go on Google and look for somebody, and they could have 5 stars, or they, if you look up, everyone's got PTSD or trauma or anxiety, depression under their little names if you're on like WebMD or whatever that one website is called. But to
mhm.
really like have an understanding of it, a lot of times it's just hit or miss. You gotta sometimes try a few counselors before you find the right one.
Yep. So, and I think with kids in the child welfare and the foster care system, this can be especially challenging
Yep.
because these kids, many of them, are inherently not going to trust people because of
Yep.
their life experiences. So, and it is important that a counselor has an understanding of that. And similar to your point about traumatic brain injury, if the counselor doesn't have a base understanding of what that does on average to a person who has suffered it, they're not going to be able to connect with that person. And then and I've talked with multiple families about this, and it's not just limited to counselors. I think it's limited. It applies to all different areas of getting mental health treatment. So it applies to psychiatrists. It applies to, different programs within a school. It applies to schools themselves. It applies to coordinators. And oftentimes, kids don't fit nicely into one little diagnostic box. As we talked about last week, many kids don't fit a perfect little box that you can easily say, okay, this is what we're dealing with. This is the person to help you deal with it. So that's a really big challenge in this system. The other thing that I think is kind of hand in hand with that is there's a lack of resources in general. So, and this is across the board, but I'll give you an example. Does anyone want to take a guess as to how many child psychiatrists are in Erie County? At least as of a couple years ago? Any guesses? Let's have a couple people throw some numbers in the chat. I just want to see where everybody's at with this.
Someone just said not many from her professional experience.
Mhm.
Alexis said 5.
So we got 10. So there's 38 in the entire county. And that's represented, that covers a few 100,000 kids. So the shortage, and the shortage again is not limited to child psychiatrists, but as a child psychiatrist, I happen to be more familiar with those numbers. But the shortage is pretty universal across the mental health system, and the system has been taxed more the last couple of years during the pandemic. So not only is it hard to make a connection, but it can be hard to find the right person in the first place. So what about, has anyone had any experience kind of working through different levels of care. So like talking about outpatient versus inpatient or long-term programs. Has anyone had any experience navigating that? Whether it's, you know, as part of a family or in your professional career? It's an area that comes up quite frequently, because what we're going to talk about is, oh, we got a couple things in the chat here. Okay. So what you'll find is that sometimes the speed needed for a treatment plan doesn't match up with the system speed. So we're going to talk about a couple of terms that kind of define how folks work their way through the system if they need to. But it also, that process, that thought process dictates how mental health professionals work through treatment options. So the first graphic here, you see two big boxes, which is how we break down the mental health system. We organize things in two ways. One is by the intensity of the service, which is where the term level of care comes from, and then the location of the services. And I'll get into that more in a little bit. And the buzz phrase to keep in mind is least restrictive environment. So that means that these different services will have safeguards built in, and they may not allow someone to pass through the gate unless you've worked through the lower level of care. And that's because it's a supply demand piece. You know, if we didn't have those safeguards, our most needed services would quickly get overrun and we wouldn't be able to get help to more different kids and families. But the other part is sometimes the work that needs to be done at a lower level of care because of the different environment we need to do the treatment in, or perhaps the different aspects of a family that we need to work on in order to have a successful outcome for a child. So, you know, keep level of care and location in mind, because I have 3 slides that all show a bunch of pathways. And those different pathways, each slide is going to be a different location of services, and the pathway is going to go in increasing levels of intensity. We're going to be talking, and those three areas are outpatient services, which can be in a few different areas. It can be in an office, it can be in someone's home, it can be somewhere else in the community. You then have inpatient services, which are in a hospital or a residential facility. And then you have emergency services, which oftentimes are still in the home or in the community, but they can be in a hospital setting too. So the first pathway that we're going to talk about is the outpatient pathway, which in general is the one that is most frequently encountered, because when somebody enters the mental health system, this is usually how they come in. And I think most people don't realize at this point that the first entrance into the mental health system is no longer like going to see a therapist or going to see a psychiatrist. It actually starts in primary care. And this is, again, because there's just not enough people to service all of the children and families that need it. So primary care physicians have had to take on an increased role over the years. And because of that, primary care physicians get more mental health training. And we've tried to create ways for primary care physicians to interface with psychiatrists, which is under the umbrella of integrated care, which is that third bullet point. So by volume, pediatricians actually prescribe more mental health medications than psychiatrists do, because of the tremendous need for kids to be seen and the severe shortage of child psychiatrists. Now, let's be frank, that's not the ideal way to do it. It's the way the system has been forced to do it because of the sheer numbers. So we have setups to help give primary care physicians more training So when primary care physicians go through their residency, they often do rotations with psychiatrists. There are different psychiatry groups that offer trainings for primary care physicians, and there are ways to get primary care physicians access to a child psychiatrist for a consultation. And it's important to keep that in mind if you're working in the foster care system, because that last piece can get a child at least some access to a psychiatrist in a more efficient way. Oftentimes, if you try to go and, if a child is referred to a psychiatrist, you could be looking at months to years of a wait to get in to see them. Whereas a consult can sometimes happen in a matter of weeks. So it's important to keep in mind that a child's primary care office may in fact be a really good resource and an introduction to getting mental health treatment. And most people don't keep that in mind. That's not what we think of when we think of mental health, the mental health system. What people do think about is are the things I have under the general outpatient part of the pathway, which is going to see a private therapist. And within that, there's therapists that specialize in different things. There's therapists that work with specific populations. There are therapists that tend to work with kids who have been traumatized. There are therapists that work with kids that have developmental disabilities. There are therapists that work with kids of different age groups, different genders, different family structures. And this window also encompasses private psychiatrists. So these are psychiatrists that are not part of an agency or a community mental health center. And I'll explain the difference in a minute. But that's the general outpatient spot. That's kind of where most people think about as the entrance to the mental health system. And for many folks, it still is. The next level of intensity is a community mental health center. And this is a place that combines access to therapy and psychiatry together. So a single agency has both therapists and psychiatrists connected to it, and it allows for easier communication between the two areas. These agencies typically have more resources to create specialized programs within their agency. So I'll give you an example. The Children's Psychiatry Clinic, which is one of the places I work at, is a community mental health center. And they have specific treatment programs for kids with obsessive compulsive disorder. They have a dialectical behavior therapy group that they do. And they're going to be developing one for eating disorders too. So these different community mental health centers have the ability to put in more intense services than is focused in the general outpatient setting. The last and most intense area of outpatient treatment are what we call intensive outpatient programs. So this is what wraparound services falls under. And wraparound services is a 6-month program that's run by the county that basically brings different types of therapy services and resources to a child's home. And it's usually happening a couple of times a week. So kids can be getting individual therapy. There can be family therapy components. There can be parent training components. There can be skill building components where kind of a role model, like a young adult role model, takes a child out into the community and works on social skills. They can connect with schools. This is where some of the specialized programs that you see in community mental health centers fall under, because the treatment is a couple of days a week. And then there's another group called Persons in Need of Supervision, which is through the legal system. And instead of like a care coordinator or therapist, the point person is a probation officer. So this avenue is for kids whose mental health systems and behavior are putting them in jeopardy of entering the legal system. So again, all of these are very intense outpatient services, but they're outpatient. So they're happening at home and in the community. There's no out-of-home placement with any of these. So any questions on that before we move on to the inpatient and residential level of care? Okay, so the first step with inpatient and residential level of care is technically not inpatient. It's kind of a compromise between inpatient and outpatient, and it's called a partial hospital program. So this is technically an intensive outpatient program, and it lasts about 2 to 3 weeks, but kids are going to a hospital setting basically for school hours. So 5 days a week, 6 hours a day, where they're getting consistent individual and group therapy. There are psychiatrists involved that can manage medications. And it's to prevent kids who are at imminent risk of going into the hospital. The challenge is we don't have one for kids in Buffalo. We have one for adults. So if somebody is 18 or older, ECMC has a partial hospital program that will service them. There is an adolescent partial hospital program in Rochester. And one of, I guess, the silver linings of the pandemic is that because of that, the pandemic, Rochester has the ability to do this program virtually, which has opened up some access to kids from Buffalo. So I've referred a few kids to this program who have done it virtually. It's the same hours, but they do it on their computer. So this is meant to prevent kids from entering an inpatient hospital. But if that doesn't happen and kids have to go into the inpatient system, there's a few different levels within that. The first is an acute hospitalization. So in Buffalo and in Western New York, the main ones that do that for kids are ECMC, which has an adolescent unit for kids ages 12 to 17, and Brilin Hospital, which I believe starts at age 5 and goes up to 18. And then both of those hospitals have young adult services. The goal of an acute hospitalization is relatively quick stabilization. So this is for kids who have perhaps had a suicide attempt, or they have suffered their first psychotic break. Looks like we have a question. Isn't Brilin closing? I would have to check on that. I actually don't know the answer to that. Brilin has inpatient and outpatient services. So Corinne, I'll have to look into that for you. There also used to be a couple of other places that had inpatient units. There used to be one in Lockport. They don't anymore. There is one in Jamestown. Obviously, that's a bit of a hike from here, but it can be used. But again, the focus is on quick stabilization and safety planning. There might be some med changes in there, but there's going to be limited use for kids that are struggling with chronic issues. So perhaps a child who has struggled with irritability and aggression for like years, and it's been at a steadily high level, that's not going to fit into the acute hospital system. And many times when folks try to get admitted there, they aren't admitted. Those kids are more appropriate in longer term settings because the problems are more long term. And so kind of segueing into the next level of care within the inpatient system is intermediate hospitalization. And in Western New York, that's the Children's Psychiatric Center. It's a little bit confusing because Children's Psychiatric Center also has a number of outpatient programs, but they have a hospital in West Seneca. And that's what serves as the intermediate level of hospitalization for kids here. The length of stay is a bit longer. It's 1 to 3 months as opposed to a few days or a week. Now, oftentimes they won't take kids unless there is a long-standing history of struggling with mental health problems. And Corinne, to answer your question, the age range is anywhere from 5 to 18. So they typically have a unit that's dedicated to younger children under the age of 12, and then they have 2 different units that work with adolescents. The format's changed a little bit since COVID, but at some point I expect they will go back to kind of the regular 3 units protocol. So this is a space for kids with more chronic mental health issues, but still at like a level that these kids are presenting to the emergency room a lot, or perhaps they've had a couple of acute hospitalizations already and they haven't stabilized. So this is a space where more complex med changes can happen. You will see sometimes kids or hospitals take what I would call a clean slate approach, where they take kids off all medicines and monitor them for a little bit before developing a new plan. Now, even though they will address complex chronic issues, the time frame is still often not sufficient to get all the way to completion. So kids will leave this hospital and there may still be some issues going on. And oftentimes the hospital will make the decision to refer a child to a step-down program or to a longer level of care, which is what we call long-term. And that's a stay of about 6 to 18 months. And this would happen in a place called a residential treatment facility. The step-down facilities I just mentioned also count in this window because kids are there for several months afterwards. But the step-down services are less intense than a residential placement, which is, kind of a separate locked unit, again, similar to the other hospitals. So kids can stay there for over a year. But again, to get to those different levels, you usually have to have failed the previous levels of treatment, and that includes outpatient. So if somebody is really struggling and they want to go to a hospital, like an intermediate level hospital, but they haven't worked with a therapist before, 99% of the time the hospital is going to say, no, you have to start at the beginning and work your way up. There's exceptions depending on the specific case, but in general, that's how this system works. You have to walk through each step to get to the next one. Any questions about the inpatient level of care before we move on to the emergency setting? Okay, so the last pathway we'll talk about is the emergency system. And a lot of people think that means going to the emergency room, and that's partially correct. But just like we try to help prevent kids from entering into inpatient systems, we also try to help kids and families navigate crises so they don't have to go to the hospital. And that starts with telehealth crisis management. So phone services that kids and families can access 24 hours a day to help work through a crisis. So for kids, the correct place to call is Spectrum Cares. Most people have heard of crisis services, and adolescents can still call crisis services, but crisis services is more geared toward adults, while Spectrum Cares is more geared towards children and adolescents. The numbers for those places will be on the resource sheet that you get. But these are, people can call these 24 hours a day for phone service. And in the case of Spectrum Cares, sometimes they can do in-person evaluations. Another telehealth crisis system or service to be aware of is called New York START. This is a service through the Office of Persons with Developmental Disabilities. So this is for kids who are already linked with OPWDD, so kids with a diagnosis of autism, kids with an intellectual disability, or another qualified developmental delay. And it's not just a crisis management service, it's a program. So kids get consistent follow-up through New York START. Whereas crisis services and Spectrum Cares are very much in the moment, particular crisis type of situation. So the next step is in-person crisis management. And this often starts with a phone call. Spectrum Cares does this. So if Spectrum Cares is trying to work with a child and a family over the phone, and it's thought that the situation can't be safely managed that way, Spectrum Cares will come out and do an in-person assessment. Not just at the home too, they can do this at a school, they can do it in the community, they will come to wherever the crisis is. Spectrum Cares will then try to de-escalate the situation so that it doesn't need to move further. But if they can't, or if they deem that the situation is unsafe, they can legally mandate that a child be evaluated at an emergency room, so at the hospital. They can't mandate that a child be admitted onto an inpatient service, but they can mandate that the child be evaluated at a CPAP. The other area that falls under this in-person category is 911 or the police, or emergency medical services. And they sometimes, so the police can also make a mandate that somebody needs to be evaluated at a hospital too. And that's the last step, is when a child has to come to an emergency department because of an acute crisis. In Buffalo, that's CPAP at ECMC. So Bryland does not have an emergency room. So kids cannot go there for an emergent evaluation. Their inpatient program needs to take referrals ahead of time, and it's not a place where a child can kind of sit there in a waiting room and stabilize. Whereas at ECMC, if somebody is evaluated there, they stay there until the evaluation is complete and it's determined whether a child needs to be hospitalized or not. Now, the University of Rochester also has a CPEP, if any of you are kind of linked with Monroe County as well. So Rochester has that capability too. Any other questions about the emergency system? Or with any of the other systems we've covered so far? Okay, so that's all I have in terms of slides. Just to give you all a preview before we open it up to questions, our next session will be in person, and it's not going to be a lecture. You don't have to hear me droning on for an hour. I'm going to have some other people do the talking with me, because we're going to do a panel discussion. And we have a really great panel that's going to be part of this from all different areas of the child welfare system. So we have therapists, we have coordinators, we have attorneys, we have, Leah Daniel, who has founded her own, resource program for foster kids. And some of these folks also serve the dual role of being foster care professionals, but also foster parents. So here's how we're going to do this. And Christy will also send out kind of an email with some info about how we're doing this. If you think about any questions that you would want to ask, and it can be based off of any of the 3 lectures we've done so far, or if there's another area about the foster care system that we haven't addressed that you'd like to, and you can write those questions out ahead of time and submit them to us. And you can also specify if there's a specific person you want to take the lead on answering that question. So you may have a medication-based question that you want me to answer. You may have a legal question that Carly Height would be the best person to answer. So if you have a sense of who you want to answer that question, let us know. And we'll send those questions out to our panelists so they can take the time to look into those situations a bit more and give you more comprehensive answers. And that will be the first part of the panel. And then we will open it up after that to general questions and discussion if anybody thinks of anything new. So I am really excited about this. I hope everybody is able to attend this. This is going to be a way to really generate some great discussion and answer specific questions that we may not have been able to get to yet through the 3 sessions that I did. So at this point, I'll open it up to any questions.
I have a question for you. With the different steps of care, is there a point at which if the child is really struggling, they are not necessarily kept with the foster family they were with?
So that would come into play more with these, with some of the longer term inpatient stays. So any hospitalization, the child is staying at the hospital. Now, there are times where part of the treatment and discharge plan is a different placement for the child. I would say that's not very common because the family that referred the child is a major part of the treatment while the child is there. And the discharge plan is generally designed around the child returning home to that placement. But while the child is hospitalized, they're at the hospital all the time. With the exception of, with these intermediate and long-term hospitalizations, and this is more pre-COVID and hopefully post-COVID, part of the treatment plan will be short but expanding periods of time back home out of the hospital. So, for example, CPC's typical format, so the intermediate hospital, they'll usually keep the child all at the hospital all the time for a few weeks, and then start to have day visits where the child goes home for a few hours for a day a week and then comes back. And then it expands to like an overnight, and then it expands to a weekend to try to help get the child reacclimated to their home environment and allow for the family to put into practice the different things that they've been working on while the child's been hospitalized. Very rarely is there ultimately a placement change after a hospitalization, but it could come up if there's like concerns of abuse or neglect in the current placement. That could trigger a change. If the general consensus is that the treatment plan isn't going to be able to be implemented well in a certain home environment, it might change. So like, for example, if a child is living with their grandparents and the grandparents have significant medical issues, and the thought is they won't be able to implement a plan, there might be discussion about another relative getting involved or something like that. But that's pretty rare. Any other questions or comments? And you can also post them in the chat if you'd like.
And I did want to do a final reminder to please let either myself or Stacy know how many will be attending on Wednesday night. And if you need childcare, the number and ages of the children you need childcare for. If you could possibly let us know by Friday, that would be great to make sure we have enough respite providers as well as order enough food.
Thanks for that, Christy.
Sure.
Any other questions or comments I can answer?
Are these programs, you know, for help in crisis, is there any like data that backs up how successful they really are at helping that foster child to really just grow up better while they're in foster care? Is there any evidence other than just calming the crisis that it actually doesn't do damage or condition them to always be in crisis?
Mm-hmm. So there is data. So the data that usually comes out of these organizations is focusing on whether kids need to go to a higher level of care or not. And the data does show that these programs have limited the number of hospitalizations that have been needed for kids. Your point about like working on adaptive strategies to handle crises is very important. What used to happen before these crisis agencies came into existence is when there was a crisis, the kid and the family would just show up at the hospital. And so there would be these kids ping-ponging back and forth out of the hospital, which was less helpful because I don't know if any of you have ever been to a hospital emergency room, but it is way more chaotic than if you're trying to handle something over the phone or in a child's home. But also it was a drain on resources because it's a lot of extra resources to care for kids in the hospital versus trying to do it in the community. There isn't a lot of the data that gets the studies that are done on this are not usually they haven't focused too much on the long-term positives or benefit or consequences of it. What I will say is one of the good things that can come out of a crisis visit is that those crisis agencies may help refer a child for services, or kind of like green lights the start of getting a child into services, so that we can work on strategies so that there's not constant calls to crisis services or the constant specter of a child having to go to the hospital, because that isn't helpful. A child ping-ponging back and forth from an emergency department is not helpful at all. Any other questions? Okay, so next week we'll be at 1021 Broadway in the same room we were last time, 6 o'clock. And, think ahead to any questions that you would like our esteemed panel to tackle, and send those to Christy ahead of time, and we will distribute those to the panelists so they have the time to look into those for you. And of course, if you don't think of any until you get there, that's fine too. All right, thanks again for showing up, and I'll see you guys next week.